Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. In this presentation, we're going to talk about global longitudinal strain, Class 101. What does it mean in 2D echocardiography in evaluating cardiac patients with various cardiac conditions, how it can be used for diagnostic purpose, what are its prognostic uses, what are limitations, and what is the future of this global longitudinal strain that is used in measuring the left ventricular function or regional wall motion changes in an echocardiogram study. So let us begin with the main feature presentation. Before we go into understanding what is global longitudinal strain, we have to understand how the human heart is structured. The human heart is a muscular pump. The human heart has three different layers of muscle fibers. The ones which are running, if you think this as the heart, here we have the longitudinal fibers running through the heart. Then when you look at the cross section of the heart, we have the fibers running in a circular manner, fibers running in a circular manner, giving rise to the short axis fibers. That's the second part. There is a third part which runs like crossways across the left ventricular cavity like this, and those are the circumferential fibers. So here, as you can see in the diagram, we have the longitudinal, you can follow my arrow, we have the longitudinal fibers, we have the radial fibers that squeeze the ventricle into a smaller cavity across the radius, and this is across the diameter. And here, this squeezes, just like you use a towel to squeeze, a wet towel you squeeze, the same way the ventricle squeezes. So let me give a demonstration of how the heart functions. Imagine this as the heart, and this is the longitudinal fiber. And here we have the circle, which is the short axis. All right. So let's just focus on the longitudinal. So the length becomes shorter. So longitudinal. But in addition to that, we have the short axis, which causes, like, instead of being like this, the heart squeezes. So the cavity size becomes less. In addition to that, we have a third movement that is going on here. First, we have the longitudinal on the short axis, squeezing, and then heart twists. See? It rotates through the circumferential fibers. This is how the heart beats. I have seen hundreds of open heart surgeries, and this is how the heart beats. It's anchored in the base, and everything moves towards the base. It moves towards the base, and this is how longitudinal squeeze, short axis squeeze, and rotation. So that gives you the idea. So let's continue with this. As you can see, just to reiterate what I showed you with the hand, here's a longitudinal fiber, here is a radial fiber, and here we have the circumferential fiber. So there is movement, the squeeze, the contraction of the actin and myosin fibers, slight gliding over, causing shortening of the myocardial fiber in all these three different directions. But when we talk about global longitudinal strain, we are basically just focusing on the longitudinal function of the heart, because this is the easiest one to measure. The short axis is usually measured more accurately with the echocardiography using a two-dimensional measurements, and also by volumetric changes in CT and MRI. But longitudinal shortening is something that is done by using echocardiography, and I'll tell you how the technique is used to determine this. And here is a diagrammatic representation of what I was just explaining to you. Here we have the longitudinal shortening from the apex to the base, the radial shortening, which happens, as you can see, on 2D echocardiography, which is extremely useful for visual purpose. Then circumferential is something that you normally don't see it unless you see a open heart surgery and standing right next to the surgeon, then you can see the heart twisting. It squeezes. You see, this is the heart like this. It becomes shorter, smaller, and turns shorter, smaller, and twisting like that. All right. So those are the three things as shown here. And all these things make the ventricle squeeze the blood. It has to squeeze 70 to 80 ml of blood with each heartbeat. So there's a tremendous amount of mechanical function involved in pumping the heart with each heartbeat. Okay, so what are the normal values? Before we get into this, let us see if I can get a picture of this. How do we measure the longitudinal strain? The way it is measured is when you do like a 4-chamber view or a 2-chamber view, you can see these the walls which are shown on the 2D echocardiography. And there are speckles. And these speckles move with the contraction of the ventricle in the longitudinal axis. And when these speckles move in the longitudinal axis, they are tracked during systole and diastole, and the difference in the speckle distance between systole and diastole is expressed as percent shortening. And that's what we see here, minus 21% shortening, 19% shortening, 15% shortening, and 18% shortening. And these are the numbers which will help us to say whether the muscle is reducing in size as expected, or is there a problem with the myocardium. And this can be either in a coronary artery circulation area, or it could be in a patchy fashion, as we see in patients with infiltrative cardiomyopathy or amyloidosis or other hypertrophic cardiomyopathies. So let's get back to, now let's talk about the normal values. The normal values of global longitudinal strain is between minus 15 and 21. If you get 21 minus, that means it shrinks by about 20%. That's a normal finding. If it shrinks by 15%, that's the lower limit of the normal, and anything below 15 is considered as reduced systolic function. This reduced systolic function could be in a certain area like the inferior wall or the lateral wall or the anterior wall, or it could be patchy. It could involve multiple small segments. And that's the beauty of this. This is the only test that will help us to identify regional wall motion abnormalities. As we get older, the values get a little different. And as you can see, I already talked about, depending upon which study you say, some of them may say minus 16 to 21. But the bottom line is, as you can see, we have these patchy areas which are showing different numbers. 19, 17, the center area is having normal longitudinal strain, whereas here there is minimal decrease in the longitudinal strain in the anterior anteroseptal area, and same thing with most of the heart except for the apex. And when you see something like this is an example probably of like an amyloid patient who has what is called a cherry on top, whereas most of the myocardium has decreased longitudinal strain except for the apex, which is spared. But anyway, as you can see, there are patchy infiltrates, and this person may have normal ejection fraction. So it is very important to understand that a normal ejection fraction doesn't mean that there's nothing going wrong with the heart, especially in patients with hypertrophic cardiomyopathy, or if they have myocarditis, or if they have if they are on chemotherapy. What are the clinical applications of global longitudinal strain? It helps us in identification, early identification of left ventricular dysfunction in hypertrophic, diabetic patients who are on chemotherapy or cardiotaxic drugs before the ejection fraction declines. And as I showed you in the previous example, there could be decreases in regional areas instead of in the normal coronary artery distribution area as we see in patients with myocardial infarction. Prognostic value. Those patients who have this patchy reduced longitudinal strain have more tendency to develop heart failure in the future or go on to develop cardiomyopathy, and hence these patients need to be followed closely and followed with tests to see if there has been change in their left ventricular size and function over a period of time. It's also useful in patients with valvular heart disease. It is less affected by the preload and the afterload, as we see that with reference to the ejection fraction. And as I said, again, with valvular heart disease, there could be patchy areas of myocardium depending upon which part of the myocardium is stressed, resulting in reduced longitudinal strain. Of course, in patients with hypertrophic cardiomyopathy, because of the disruption of the myocardial fibers and fibrosis, we may see varying degrees of patchy areas where there may be reduced global longitudinal strain. Valvular heart disease, we already talked about this. Let's move on to what are the prognostic values of doing a global longitudinal strain. It predicts the outcome in patients with heart failure, ischemic heart disease, aortic stenosis, and in dilated cardiomyopathies. It outperforms ejection fraction for risk stratification. I want to underline that GLS outperforms ejection fraction for risk stratification in patients with heart failure. So I think if we have a patient with hypertrophic cardiomyopathy or patients who have aortic stenosis, people who are on chemotherapy, it is imperative to do the GLS because this will serve as a much better parameter in follow-up studies to say who is at risk of developing more significant cardiovascular problems down the line. It is associated with mortality in heart failure with preserved ejection fraction. We know the ejection fraction normal doesn't mean the heart is normal because there could be areas of myocardium which are not functioning and they can get worse over a period of time, and unless they are closely followed and appropriately treated, the condition could get worse and patient may have significant symptoms. All right, what are the expanded indications? Guiding therapy in patients with heart failure with preserved ejection fraction and valvular heart disease. It helps us to monitor cardiotoxicity in oncology patients. You do a resting study and you do a study 3 months later, and if you see some changes, maybe that's the time to consider or reconsider the chemotherapy regimen. And there's growing evidence that it should be included in the routine measurement of 2D echocardiography and studies, especially in patients with heart failure and cardiomyopathy. It is poised to become a cornerstone in cardiac assessment, complementing ejection fraction with its superior sensitivity and prognostic utility. There are limitations to the global longitudinal strain measurement. First of all, we are just measuring one aspect of the 3 different components of myocardial function, which is the longitudinal shortening, the radial shortening, and the squeezing and twisting effect of the heart. We are looking at just one, there are limitations because we are not looking at the other ones. The other ones, the shortening, radial shortening can be measured with ejection fraction or using more accurate measurements like nuclear studies, CT or MRI. whereas with echo, it may be sometimes difficult, even though we can use Simpson's method to get a fairly accurate ejection fraction based upon the radial shortening. The biggest challenge is tracking these speckles in patients who are having these global longitudinal studies. The speckles are sort of tracked using different algorithms by different machines, so you can't compare studies from one machine to the other. Number two, the technique also makes a significant difference as to how these images are being tracked. And also, it only gives information with reference to the longitudinal strain and not the other two. There is no standardization of how these are measured and how the calculations are done and how these results are compared with different studies from the same patient. So there's a lot of room for improvement when it comes to making global longitudinal strain more standardized so that it can be applicable in a vast number of patients, especially with hypertrophic cardiomyopathy, who are on chemotherapy, or those who have heart failure or cardiomyopathy. So the expanded will be to use this in patients with preserved ejection fraction heart failure, monitoring cardiac toxicity included in the guidelines as a routine for evaluating left ventricular or regional left ventricular function while doing echocardiography. So ladies and gentlemen, the future is, of course, to standardize the measurements so that it would be sort of cross-platform uniformity, so that one study done in one machine can be compared with a study done in another machine at a different time, and it will help us to guide in terms of treatment, in terms of evaluation, follow-up, and hopefully maybe change the outcomes in the long run. And here are some examples I'm going to show you now. Here is an example of a slightly reduced in the base, whereas the rest of the area is moving okay. And when we see something like this, you worry about, is there an early sign of reduced? But this is normal. So, and let's look at this one. This is, and again, just showing how these are all tracked by the software that comes with your machine. And here's an example of a patchy areas where there is decreased longitudinal shortening of the myocardial fiber. And here's an area of example of a patient with amyloid disease with hypertrophic left ventricular size with normal function, perhaps maybe some small pericardial effusion. And you can see there's significantly reduced longitudinal strain in the anterior, septum, inferior, and the lateral wall with the sparing of the apex. This is what is called as cherry on top, which is diagnostic of or significant of images seen in patients with amyloid heart disease. It could be seen in other infiltrative heart conditions also. And this is an example just showing how these speckles are tracked and during systole and diastole, and from then the shortening fraction is measured in different regions, in 4-chamber, 2-chamber, 3-chamber, and the average is taken to summarize. So ladies and gentlemen, this is a quick overview of a global longitudinal strain and how it is done, what is the concept behind it, and what do we measure, how does it help clinically, and how can we expect this to be useful in the future. Thank you so much for watching, and please do subscribe to our YouTube channel. I will see you in the next presentation.